Today we will discuss a topic on Phylloides tumor. The word Phylloides tumor is derived from a Greek word phylloides, which means that it's a leaf-like structure. It's more of a benign condition. Almost 90% it is a benign. Only 10% it can transform into a malignant. Phylloides tumor was also known as a histosarcoma phylloides or a pseudocystic disease of Brody. The term cystosarcoma phylloides is now considered inappropriate or a misnomer. Why? Because it is neither cystic nor a sarcoma. Hence, the term is now considered inappropriate. Phylloides tumor is considered more of a distinct pathological entity. Why? Because it has a stromal proliferation. You see in histology, there is stromal proliferation with increased cellularity. They form your glyphs. You see on histology, you will have a clear picture or idea. Then there may be a heterogeneous components. What does it mean? See, the stroma, there is high cellularity. In addition to this, there may be fibroblast cells present leading to fibrosis. There can be both cellularity with fibrosis. You will get an heterogeneous appearance. Also, it can have a mitosis. See, mitosis of more than 10 is considered a malignant change. But it is seen only 10% of phylloides tumor can undergo a malignant transformation. We will talk about it later in this lecture. It's termed as a biphasic proliferation. What does the term biphasic proliferation mean? Biphasic proliferation means that it has a stromal proliferation plus there is your mammary ductal epithelial proliferation. It's called as biphasic proliferation. It's mammoglobin positive. If you see on histology, these are your ducts with the epithelial proliferation, ductal epithelial proliferation, plus these are your stroma, in which there is increased cellularity with your fibroblast. So it's more appropriate or more of a pathological entity. See this picture again depicts these are your large ducts in which there is lined epithelium, and these are your glyphs which are formed by your stromal proliferation and fibroblasts. Next, we will see what are the clinical features. See, it's most commonly seen around 30 to 60 years. Women with complaints of a large or huge breast lump breast lump. Even though it is a large, it is mobile. Since it has a huge volume of a breast lump, it can undergo pressure necrosis, sometimes ultimately lead to ulceration. It's also possible. So this is your gauze picture, which is showing some of your dilated veins, and you can very well appreciate a huge tumor-like mass with your bossy-lated surface, which keeps it mobile. As a bossy-lated surface is a distinct feature of phylloides. Moving on to investigations. Usually any breast lump, it is followed by a clinical examination, radiological investigation and pathological investigation, which is called as triple investigation. Whereas your clinical examination, your ultrasound or mammo or your FNAC, all of these things are of less diagnostic value, because it cannot differentiate it from your fibroadenoma, especially your epithelial fibroadenomas. So your true cut biopsy would be your preferred investigation of choice, although your definitive diagnosis is based upon excision biopsy. Also here in the investigation, I want to tell brief on your role of MRI. MRI can pick up to 70% of your phylloides. Next, coming to your diagnosis, there is a name classification based on your pathology or histology, named after Azzopardi Savarinuri criteria. What is it? So they take into 4 features, such as 1. Your tumor margin, your stromal cellularity, your mitosis rate, and pleomorphism. They classify into 3 types: benign, borderline, and malignant. I already told you it is mainly of a pathological entity. In your benign cases, the tumor margin is just pushing, mobile. It is mobile, so it's just margin is limited, or it's pushing. Whereas in your malignant, it is infiltrating. Coming to stromal cellularity, there is stromal cellularity, but when compared to malignant, it is low. Malignancy is very high. Here it is intermediate. It's equivocal. Mitosis rate, it is less than 5, it is 5 to 10, it is greater than 10. Pleomorphism, here it is mild, it is moderate, it is severe. So your malignant phylloides will have an infiltrating margin, very high stromal cellularity, mitosis index of 10 per HPF, and a severe pleomorphism. This is based upon your Azzopardi and Salvadori criteria. That's Paddington criteria. So when you will do a true cut biopsy or for a case of phylloides. So I want to make it clear for you what does the terminologies mean. What is your mitotic activity? Mitotic activity here means there is evaluation of your cellular areas, more cellular. Where it is more cellular, the areas are assessed and quantified per 10 HP. Second thing, what do you mean by stromal homogrowth? There should be stromal proliferation but without accompanying epithelial elements in at least one low power field. Infiltrative tumor margin, what does it mean? Means that there is a projections of your tumor stroma into your peritumor stroma or adipose tissue. Clear? So these mitosis rate means there is an evaluation of more cellular areas you assess and quantify it per 10 high power field. If it is more than 10, then it is a malignant phylloides. You look for stromal cellularity. What does that mean? Stromal outgrowth means that it should be accompanied by absence of your epithelial elements, minimum one low power field. And what is infiltrating tumor margin? It is the projection of your tumor stroma into your adjacent adipose tissue. Understood? Next, I want to emphasize on metastasis. Does phylloides tumor metastasis? If it undergoes malignant, it has to go metastasis. So your root, it is your root of metastasis. It's a hematogenous metastasis. It's not a lymph node metastasis. So what is the importance here? So there is no need for any lymph node dissection. There is no need of any lymph node dissection. So what is the most common site of metastasis? It is your lungs. Can metastasize to bone, etc. Most common is your lungs. So moving on to your management. So we have classified into a benign and a malignant. If it is a benign tumor based on your histology, that is your Azzopardi and Salvatore criteria, then your all phylloides must be treated like your soft tissue tumors. That is, you must give a wide local excision. So that your tumor is margin negative, because it has been reported in your literature there is increased incidence of recurrence. In order to avoid it, you have to always give a wide local excision. What do I mean by that? See, in this picture, this is your tumor, this is your normal tissue, so this is your margin. We have taken this as a margin so that your rest of the tissue is free from your tumor load, This is called as negative margin. Suppose if you are not giving, this is achieved by your wide local excision. That is, you are giving a negative margin, say at least 1 to 2 centimeter. If you are not doing a wide local excision, there is a more chance that you leave a tumor load. So it becomes on histopathological report positive margin. There are more chances that it recurs. So always remember, benign phylloides, you have to treat it as a soft tissue sarcomas, or you give a wide local excision always. Next, coming to your malignant phylloides. How will you manage your malignant phylloides? It's simple. If it is malignant, you do a mastectomy. But you will do, here comes the question, will you do lymph node dissection? Answer, I told previously, there is no need. Simple mastectomy will suffice. But suppose if your phylloides, malignant phylloides, involves a chest wall or fascia, then comes your role of radiotherapy. Then you have to give radiotherapy with your mastectomy. Understood? So, what are the indications of mastectomy? In phylloides. One, it is a malignant change to, if it recurs, then you have to do, and if it is a very massive tumor, you can do a mastectomy. So we are in detail discussed about your phylloides tumor, management of your phylloides, benign, malignant. Benign, you always do a wide local excision, whereas in malignancy, mastectomy with the role of radiotherapy if it involves chest wall or your fascia. Then on a brief note on your metastasis, the most common route of metastasis is hematogenous, most common organ or site is lungs. Then I have told about the Azzopardi and some of the criteria for your diagnosis of your phylloides, and true cut biopsy is your preferred mode of investigation of choice. Here also I told you, remember the name Paddington criteria for doing a true cut biopsy in the case of phylloides. So I have finished a topic on phylloides.